always, every time I'm just like, whoa.
Yeah, we're live now. Okay, awesome. Yay! What's going on, Facebook? Welcome back to another episode of the Late Night Show with Dr. Kojo. And I have a very, very special guest, a psychiatrist, a good friend of mine, and somebody who's going to be talking to us about ADHD and autism. And this is a very requested, live because I've been seeing you all's comments. You all's is that a word? Either way, I've been seeing the comments in the chat whenever I go live. So I want to make sure that I give you all the correct information in the best possible way. So before I bring him on, I want you all to go ahead and let me know where you all are checking in from. Brittany is checking in from Kentucky. Brittany, what's going on? And Juana says, ooh, let's get it. Let's get it. Sarah says ADHD and autism here. Awesome. Yeah, a lot of people don't know. A common question I get is, can people have both? And we'll talk about that. Minnesota in the house. Jay Jackson. Jay, how are you doing? We got Taylor from New Jersey. My son's diagnosed with both. Oh, yeah, we're going to get into it. Samantha, we're going to get into it. We have Tennessee in the house, Pennsylvania, Ohio. We have Texas in the house. Okay, so everybody is well represented here in the chat. Tennessee, Virginia, Michigan, Indiana. Someone says flaming ADD and flaming, okay. In Maryland, Arkansas, New York, Queens, New York, Texas. Okay. Awesome. We're doing great here today. So I'm going to go ahead and bring my friend in and let him introduce himself, and we're going to get right into it. So without further ado, my friend, Dr. Sood.
Hi, everybody. Oh, man, you're awesome, Dr. Sarfo. I really appreciate this. This is wonderful, and this is a very cool venue. You're introducing me to the Facebook world, so hello, all of you. And I'm just super stoked to be here. Just very lucky. First and foremost, I think the proudest thing is that I'm good friends with Dr. Sarfo. We've been working together for a couple months now, and he's brought me into the social media world. So thank you, good sir.
Appreciate that.
And I see some people from Virginia. I'm originally from Virginia. I'm a adult psychiatrist as well as training in child and adolescent psychiatry as well. And I live up here right now in New York, practicing and seeing patients in the adult world as well as learning child and adolescent psychiatry. So I trained at NYU as well as New York Presbyterian, Cornell, and Columbia. And so I'll try as much as I can. I am not a pure end expert in autism and in ADHD, but I've been trained in it. And I will try to present as much evidence-based medicine and facts about it so that you guys can feel a little bit more up to date. And in the best way possible. And if I make a mistake or anything like that, let us know in the comments. We'll try to slow down. We'll try to keep up.
Yeah, but I mean, you are, and for those of y'all who are watching on Facebook, Dr. Sue is one of the OGs. You know, he has a wealth of information. He's somebody who I ask, for tips along the way. So he's going to break down ADHD and autism. And I think, what better person to hear from than him. And he also is on TikTok posting. So he has a way of, explaining these things for people to get it. So I'm excited. And, why don't you go ahead and let the people know. First, define ADHD, and then define autism, and then talk a little bit about, maybe some of the similarities and differences.
Absolutely. So I think the most important thing is, like, why don't we start talking about autism? Because I think ADHD gets a lot of, I guess, clout or like a lot of attention.
True.
And autism, I think, is in my professional opinion, can be really incredibly difficult to kind of like really assess and diagnose. Yeah. And I'm saying that personally because it's something that was something that is still developing and evolving with the changes in the DSM-4 and DSM-5. So with ADHD as well. Mm-hmm. But just for me personally, it's something that I've learned a lot more recently from really esteemed professors who've taught me and my patients who've shared wealth of information. And so I think the first thing that I talk about is that, there's a rising prevalence of autism, but why? Exactly, in past years, it used to be 1 in 166 people were diagnosed with autism, but now that number is down to 1 in 54. And why is there an increase in
Wow.
that number? Yeah. So there's been a rise, and we're kind of trying to figure out why. And I think the big jump is that there's better tools. So the youngest age that we can diagnose autism is around 2 years old. So we can make that diagnosis through really highly sensitive and specific screening tests that developmental pediatricians can use to kind of get a better understanding of, is this some child that we need to be kind of aware of and think about and kind of assess for symptoms. And so I think that's like a big thing that's kind of coming out, is that how to assess appropriately, and that can be done at a very young age. I think also one of the big things, and I have my notes scrolling, so you'll see my sides because I just want to make sure that
We love it,
guys, the right
we love it,
because I'm human, so I will definitely forget, and I want to make sure that I'm talking about this. But I think somebody pointed out gender, and I think that's a big point. Gender ratio in ASD is highly dependent on IQ. There are many more males than females that are being diagnosed with autism, and historically, we would catch a lot of females that had low IQ, but now we're getting a way broader scope and representation of those who have IQ. And the reason why I say it's very prevalent is because a lot of people confuse intellectual disability with autism, and those are two separate diagnoses. They are not one and the same. They are highly comorbid with each other, meaning that they're very common with each other, but they're actually separate diagnoses. In kids under the age of 5, we think of what we call global developmental delay, where they're missing their developmental milestones. This is not autism. This is a separate diagnosis. Autism, which I will talk in a second, which has specific criteria, can have intellectual disability as a co-occurring psychiatric condition. So I think it's really important to keep that up.
Right.
And there's definitely different gender ratios right now, but what we're knowing now is that it's starting to equal out a little bit more. And that is, again, from screening, right? And looking at these things. So a lot of people are identifying with these traits now because it's becoming a lot more prevalent. We're learning a lot more about it. And Dr. Sarfo, cut me off anytime that I'm rambling.
No, I love it. I love it.
And so I think kind of if we were to look at the diagnostic criteria, and so the basic thing is that in the DSM-5, there are 2 domains when we think about autism, right? In one domain, there is the impaired social communication, which is what we call social reciprocity or social emotional reciprocity, and nonverbal communication and deficits in nonverbal communication. Or again, in language, right? Because we're learning about ableist language, this would be seen as just differences in nonverbal communication, not a deficit. And so there's that aspect, and also differences in relationships and how relationships are viewed and how they're interacted with. So this is the one domain, which we know as social emotional reciprocity and impaired social communication. There's the second domain, which is restrictive patterns or repetitive patterns. And this would look like repetitive speech or behaviors, instances of sameness, as well as sensory abnormalities and restricted interests. So 2 out of 4. Now, our supervisors told me that we came up with autism, and the question we always screen is the child fascinated with trains? Are they fascinated with trains? And that became the question for some strange reason, because that was displayed in the media. And that's what kids with autism, they were just fixated on trains. That's not necessarily the case. There might be a fixation on dates or automobiles or specific interests that are fixated and focused. What becomes really common in a lot of autism, though, is that autism comes with comorbid conditions. That is typically the norm, and it's not the exception. For example, you don't just see a kid with ASD, autism spectrum disorder, and nothing else with that, because it's a highly comorbid condition. And that's why it gets super confusing. Because then
Right.
people are putting all of the comorbid conditions with it and are saying, oh, ADHD and autism are the same thing. They're
Right.
not. Intellectual disability and autism are the same thing, which they're not.
You see that all the time. Yeah.
Exactly. Somebody said here, could autism be misdiagnosed as OCD? Absolutely. A compulsion that occurs over and over and over again, right? And somebody starts like counting numbers and somebody says, oh, that's a fixed interest. And that gets considered a restricted, repetitive behavior. So it's definitely always a possibility that diagnoses people can be misdiagnosed. That's why screening tests are really important. I think for the audience, if you want to know what good screening tests are available for autism for children 2 and up and 3 and up and 4 and up, there's the MCHAT, which I don't have those notes up, but it's a screening test for autism. There is the SRS and the SQC, which are standardized questionnaires for autism. And then there's the gold standard, we think, in clinical work. It's called the ADOS-2. And that exam is a 45 to 60-minute evaluation that's done for certain ages. So there's one for toddlers, there's one for 1 to 2-year-olds, there's one, for toddlers with phrase speech 2 and 3-year-olds that have phrase speech, 3 and 4-year-olds, 4 and 5-year-olds, 5 and up, and adults. So there are testing that you can do for adults as well. So I think it's incredibly important to know. All that being said, autism, to be diagnosed with autism, it's a clinical diagnosis, meaning no matter how many tests you do, you still have to consider, right, from the clinical observation of the practitioner, like, yes, this is autism. This is from what I see and from what's happening in the diagnostic testing, this is autism. So there is no gold standard blood test or anything like that that's going to say this. Right. And I think that would be really important.
Yeah, and I see a good question here from Samantha saying they've never been diagnosed, but they think they have a similar diagnosis as their son. Does it mean that it will continue genetically to the grandchildren? That's a good one right there.
That's a great one. So genetics are important. Absolutely. I don't have the numbers off the top of my head, but psychiatric illnesses are genetic in nature. We know that bipolar disorder, schizophrenia, these things do get passed down. And it's really important to take a family history when you do a psychiatric evaluation. Does that mean that you have autism or you have ADHD, so your child will have it? No, absolutely not. But it does mean that it increases the risk of developing it or having it. So that's why during any psychiatric evaluation, I definitely always do a full family history. It is so important because you get a really good idea of like what's there, what to think about, what's potentially could be coming down the line. And so that is definitely a great question. I don't think it's something that you're absolutely have to expect because I think that would be really stressful. And then we don't have the genetic testing for these tests, right? They don't automatically determine that you'll have it. And I apologize as I'm doing this, my cat is pulling my cord, so I'm gonna move this a little bit.
I can relate because though I put her up in the crate, but she'll be out here, she'll be scooping things, and she waits for me to go live. Like she'll be fine if I'm just like hanging around. And the moment I go live, she wants to go somewhere and like pull on the computer cord. The moment that I can't reach her, it's like a pet thing. They wait for us to get busy and then they try to distract us. Oh my goodness. And, I thought a good question here, and I've definitely been asked this before, I think on Instagram, but what are some of the things that a parent might want to look for in their child, and okay, well, maybe we need to see a pediatrician or maybe we need to see a psychiatrist. I think this could be, autism.
Oh, excellent question. I appreciate anybody who asks that type of question because we know parents, you guys are doing such an incredibly amazing job trying to raise your child. And you're obviously seeing these things on social media and you're seeing these things in the news and you're automatically thinking, does my child have this? And I think the first thing, you always have to think about is developmental milestones. Is your child hitting the appropriate developmental milestones at a certain age, right? 1 to 2 words at the age of 1 or walking at the age of 1? How many blocks do they stack up at a certain age? There's so many different developmental milestones. And so the American Academy of Pediatrics has a really good guide for parents to look at developmental milestones that's easy to read. You can just Google American Academy of Pediatrics developmental milestones and just check that out. And you can kind of gauge like, okay, is there something that we're missing here that our child isn't kind of getting to that we need to bring up with our pediatrician, right? Again, don't use it as a diagnostic tool, but it automatically tells us, are there developmental milestones that are missing, right?
Because
American Academy of Pediatrics developmental milestones. And that's a good way for parents to kind of start looking at these things if they're interested. I think additionally, right, developmental screenings for toddlers begin at 2, but they even occur earlier than that, at 9 months and at 18 months. But you're looking at like eye contact, solitary play. Are they able to engage with the parent? At 2, are they able to engage with the psychologist or the therapist? Are they having imaginary play with whatever toys that are available? How are they playing? Again, this is not something that the parent needs to exactly know, but if there's a concerning aspect where there's that lack of social emotional reciprocity, I like to think of it like this. In development, when we think of kids growing up between the ages of like from birth to 5, right, they use their parent as the mother or the father as a way of kind of refueling. So they go out, they explore the area that they're in, they look back and they check in with mom or they check in with dad, like, is this safe? Is this good? And then they feel safe and then they'll go out further and further. And so when we look at that and we think of in autism, like, are they checking in with their parents? Are they using that eye contact and like kind of checking in and having that social emotional reciprocity? Or are they fixated? Do they not respond to what they're hearing or what they're listening to? These are the things parents might start to notice at 1 or at 2 or at 3 with their speech. Are they having 1 or 2 words at 1, 2 or 3 words, and then there's an explosion of vocabulary, 25 to 50, 50 to 75 words around 2, 3. Are they not having that speech? Are they not having those words that are coming out? That's when you start thinking maybe we should talk to the pediatrician about this. So there are little keys.
And on the flip side, I have a lot of friends since I've been posting on like TikTok, IG, and Facebook, who will come to me, and I'm not an expert, on autism, so like I'm right there with you. I'm learning, and they'll ask me, I feel like I'm in the spectrum, where would I start? So for an adult who feels like they might have autism, do you think there's any value in seeking a diagnosis? And where would they start?
That's a loaded and fascinating question. You're asking all the tough ones today. I love it. So I think to think about that, right, you have to think about functionality, and you have to think about, so when we're thinking about diagnosing autism and it's happening at a young age, right, we're thinking also about genetic testing. Somebody asked about this, and I'll get to this in adults, because we were thinking about comorbid conditions. Fragile X is very common, which is a genetic illness that occurs with autism, and you're doing also other genetic illnesses that occur, and it's just something that we would, in a young age, we would test for and check for. You get to the adult world, and then there's this consideration: do I have autism? Do I not? There is the ADOS-2 screening exam that you can do by a guided clinician, which will give you those, which will help you with the therapist figure out, or with a person who performs this test, figure out, okay, maybe I do have some clinical features of autism that highlights a lot of the ways I do things. Awesome. Okay, how does that change your trajectory? What does that change? Does that mean that we need to get you extra services like social groups in which you can kind of work on social cues, or if you feel like that needs to be worked on in any which way? Does that mean that we need to help with like textual aversion and figuring out how we can get around that if that really bothers you? right? Whenever I think about a psychiatric illness, I think about not just what the diagnostic criteria is, but how it affects functionality in ways, right? And what that means to the person. Because somebody might say, yeah, I have autism, but it doesn't bother me. I like it. It's fine with me. And for me, when I hear that and it doesn't affect their functionality, I'm not thinking about meds or groups or anything of that sort.
Right.
I'm thinking about, great, fantastic. That's awesome. If you want to pursue treatment for it, if you think that they need treatment for it and they have insight in the fact that, right, you look at people who have autism and in their lack of their social emotional reciprocity, they're unable to get into relationships with friends or other individuals, and they become significantly depressed because of that, right? Then you ask yourself, okay, how as a physician or how as a mental health provider can I check in and how can I help them?
Right.
The goals are to learn how to interact in a way that they can maintain those relationships, and would that be more helpful for them? So you're looking at the areas in which their functionality and where they feel like it's not helpful that you can help out.
Yeah, that's a fantastic answer. I love that, because you might have somebody who, let's say they did pursue diagnosis and they were 25, but the diagnosis helped them understand themselves better, and maybe they were struggling in relationships, or maybe they were struggling in social situations, and maybe it was like damaging their self-esteem. So
Absolutely.
yeah, I like that you zoned in on the functionality, because sometimes I think, and the general public will probably look at, probably a psychiatrist and say, oh, they want to fix every single thing, but it's about meeting your patient, where they want to be met at. And I think I appreciate you saying that, because it's helpful for a lot of people to know that there are, professionals and psychiatrists out there who want to not just slap a label on you, but they're more so focus on how can we figure out a way to help you improve your life. And if you don't need any help at this time, then okay, I'm going to be hands off, but I don't want to really put a label on you, because sometimes I've seen it a lot where people are afraid of a certain label and they've got to 30 years old. They're like, okay, I don't need to be checked out for this, but I think I have it, that type of thing.
Absolutely. That's absolutely it. It's meeting them where they're at, seeing what's functionality. And right, you're getting a lot of these referrals for kids that are 5, 6, 7, 8, 9, 10, right? So for them to voice what they really want, it's really difficult for them. They're learning the world. They don't know what exactly they need. It's very frustrating for them. So you're working with parents to figure out where these difficulties that your child is going through, how is it affecting their life to the point that you notice it as a parent, that you're worried about what's going to happen in the future. And as the provider, you help decipher, right? So it really is a joint kind of work, doing joint work together.
And I see this question right here. Jamie Jennings, masking. I was told today by a student nurse, my daughter doesn't look autistic or ADHD because she was not out of control. What are your thoughts when it comes to masking, with autism and also with ADHD?
So I think masking is an interesting term. I'm still learning a lot about it. When I think about, let's talk about ADHD. ADHD is a clinical diagnosis that's made on an observation scale by the clinician in the setting that comes from both the outpatient setting, but also comes from another setting. And it can be in home, and it can be in the schoolroom. And we've talked about this in previous lives on TikTok, but I think it's really important. When people say they're masking and they're hiding symptoms, severe ADHD is really hard to hide symptoms. And what you end up finding out is that in the home and in this classroom, these symptoms come out at different times. And so there's different screening tests we do called the Vanderbilts or the Connors or the SNAP, which you give to a teacher and you give to the parent. And you say, let's fill it out. And if one or two, and with parents, with teachers, I typically send it to 5 or 6 different teachers, right? And really want to get a varied response, right? Because if it's severe ADHD, scores should be popping up in each of them, right? That's why you want to get it at different areas. If you have really bad scores in one setting, but totally fine scores in the other setting, you have to ask yourself what exactly is going on in the setting that is causing this. So when it comes to I mask symptoms, I really kind of think, okay, when you mask symptoms, if you're not masking, what does it look like? And when you're not masking, what happens? Who comments on it? in the adult population, I sometimes ask a patient, hey, can I speak to your partner? Or can I speak to your friend that you adore with your consent? And let me ask them, when you're not masking, what does it look like? And that person will be like, they lose their keys, their wallet, their phone. They're late to everything. They're off in La La Land. I've heard space cadet before. Not great terms, but I mean, like,
yeah, I've heard those same ones. That's why I'm laughing. I'm not laughing at the term. I'm laughing at the fact that I've heard like those same verbatim ones.
Yeah, and it's very much a kind of like you want to gather collateral information. It's so important. I've talked about this before also. You can't really upscale psychiatry, and this is a total tangent, but like we were talking about this before, right? Mm-hmm. Gathering collateral information from multiple sources. Psychiatrists, nurse practitioners, PAs, anybody who's working in the mental health field, you're a detective. You're really trying to get in all this information because you don't want to just take one source and say, yeah, this is it. Here's a med, right? That's lazy medicine. You can't do it like that. You have to do really, really kind of focused on like, let's gather all the information. So when I think about like a teenager or I think about an adult, like an adult in a college class, for example, get consent to speak to the guidance counselor. Get the school dean or whatever, I can't remember now. Whoever's the person that works with
not superintendent. I forget what they call them. The counselor, I forget what the term is, but the person who helps them with the curriculum in college, right?
Yeah, absolutely. Yeah, the curriculum person, whatever have you. That general idea. And I'm like, I was in college like 10 years ago. Why am I forgetting this? So I think what's really important is you gather all this data from teachers and professors, and you look at it and you say, okay, look, this person has inattention throughout all their college classes. They're not depressed. I've screened them for anxiety. They have a little bit of anxiety, but what really comes out is that they get really anxious when they don't turn things on time. And it really, advisor. Thank you.
Advisor.
Thank you. I appreciate it, Katie.
Shout out to Katie.
Yes, thank you. You saved us there.
Oh my God, the advisor.
So yeah, it's really, really important to gather extra information. And when we gather this extra information and we look at like, okay, like, right, if I think of what's a core symptom of ADHD, inattention, for example. Exactly. I get really nervous with quick diagnoses. Absolutely. Quick diagnoses are not good medicine. We have to think. That's why you go to residency for adult psychiatry for 4 years and then child psychiatry for 2 years after medical school. It is very, very complex. But think about like inattention as a bubble. If we think of inattention, that's a symptom. If somebody is traumatized and daydreaming because they're dissociating, that leads to inattention. If somebody is super anxious and they're having racing thoughts and they're not able to focus on the work, that is inattention. If somebody has sleep apnea and they're totally sleep deprived and they're inattentive, that's inattention. Somebody could say, I have inattention, I have ADHD. Well, actually, it could be any of these things. Mm-hmm. And that's why it's really important that we do a thorough assessment. There is a tendency to diagnose males more than females because males fit that prototypical, impulsive, jump out, constantly grabbing attention, and everyone's like, they have ADHD. It's very hard to catch the inattentive females, right? They get misdiagnosed with anxiety and depression and trauma, which all could be there, right? But it's just good to kind of get that assessment.
Right. That's awesome. And when you talk about women with ADHD, it's something that I've talked about, at length, on social media. But what are your thoughts when it comes to women with ADHD and getting diagnosed later in life, and sometimes not knowing until, honestly, sometimes like from what I'm seeing, I have no evidence to back this up, right? But from what I've seen on social media, sometimes like they'll write on the TikTok or on the Facebook reel or IG reel, I did not know until somebody sent me this video and I went to my doctor. So what are your thoughts on women with ADHD and, that whole ordeal?
I think ADHD is really important, and it's something that we need to assess in women. I think you need to do a thorough psychiatric assessment. I think if a woman comes and says to me, I have ADHD and I have symptoms that have fit the DSM-5, I'm like, great, let's go through your developmental history. Thank you, Maureen. I really appreciate it. And let me know if I'm not, of course. Any feedback is feedback, right? We got to keep learning ourselves. But always getting a developmental history is incredibly important. And again, kind of highlighting like if somebody lives with you that you really trust, getting that information from them too. Because if you have ADHD and you're quote unquote masking, and the best person in the world around you says, hey, if you're masking really good, and I know you really well that I've never seen you unmasked, then I get a little bit curious about that, because typically if you're masking, you're compensating in some way, shape, or form, and that's tough. That's hard. And so somebody had posted, I think on one of my TikTok videos, I'm a successful woman that masks for so long. And I am successful, but I mask, and that's why I have ADHD, because I know how to compensate. Well, absolutely. But what do you do when you don't need to compensate? That's always the question I think about. And who sees you when you don't compensate? Let's talk to them. And if they also say, yeah, when you're not compensating, you're kind of like, we clearly have a significant downcline in your functionality. I'm like, sure. Absolutely. Let's try a trial of stimulant after we've done a good cardiac assessment, after we've looked at your family history, after we've thought about labs, if we need to get any lab work, right? Prescribing a stimulant isn't like the scariest thing in the world. It's very easy for me to do. It's very easy for you to do. Right. But it's one of those things where people feel like you can give them out like candy, and no, you have to do a full thorough assessment. And a full thorough assessment requires this type of legwork. It can't just be, you have these symptoms, therefore, right? It's dangerous. It's not, it's medically unethical. So yeah.
And all right, so guys, we're gonna keep this going for 5 to 10 more minutes. And I'm gonna do rapid fire and ask Dr. Sue a couple of questions. So this is a question I get all the time, but how would you describe the difference between ADD and ADHD?
Semantics. There's probably I don't know the historical narrative behind this change. I can't remember exactly right now. So if somebody quotes me and says, oh my God, the psychiatrist doesn't know the difference. If somebody came in with ADD or ADHD, I would be assessing for all of those symptoms: the attention, the hyperactivity, the attention deficit disorder, attention deficit hyperactivity disorder, right? I'm assessing for all of those things, no matter what, if you're coming in for that assessment. So by the diagnostic standards, yeah, there's attention issues, and then there's one that's hyperactive issues, and then there's combined presentation to be considered. But I'm assessing for all of those symptoms if you come in for an ADD assessment or an ADHD assessment. I think you're just looking at inattention versus hyperactivity at that point. Again, I would encourage everybody here, if they're curious, look at a Connor scale or a SNAP scale, Google it. It'll show you kind of like the symptoms you think about when you think about inattention or hyperactivity.
Oh, for sure. And I saw a good question, but someone says, please tag the guest speaker. Let me drop in your, what's your TikTok again?
PsychDoc TikTok, PsychDocTik. Is that TikTok?
TikTok. Like that?
Yep, that's it.
Boom. All right, so everybody who's watching, maybe 2 more questions, but go ahead and give Dr. Sue a follow on TikTok.
You guys are
at PsychDoc TikTok, and I'm gonna move on to the next question here. I saw a really good one. Ooh, right here. From Kamisha Tiggs. Is there such a thing as growing out of autism or ADHD?
Oh, that's a great question, Kamisha. I really like that question because I think ADHD, so we'll look at ADHD first, right? ADHD you're born with. I think there is this idea of adult onset. I don't necessarily agree with that. I think there was commenting on that before. I think we do live in an environment that is incredibly distracting during a pandemic. So it's easy to develop these symptoms and say, oh, this is onset ADHD. I think this is something that people are born with. This is a psychiatric illness. There's psychiatric history. And I think that kind of develops over time and you kind of start seeing it. Do people grow out of it? The frontal lobes develop. So if we were to think about a quick neurobio, I'm sorry, guys, so geek out with me for a little bit.
No, we need it.
If we think about the neurobiology, right? If we think about what we call the prefrontal cortex, it's the front portion of your brain. It is what we call the executive function functional center. It is our executive control. And then when I say executive control, I mean what controls our impulses, what controls our judgments, how do we plan our day, right? That part of the brain is the last part of the brain to develop, and it typically fully matures not at 18, not at 20, not at 22, but 26. So that part of the brain fully develops then. And when you think about what that part of the brain is in a basic sense, like if we were to think about like a car, it's like the brakes of our brain. It slows down parts of our brain around here called the amygdala, and it basically slows us down to not make impulsive decisions. And so in ADHD, we think there's issues with that part of the brain. So we prescribe, now think about the oxymoron here, a stimulant. We stimulate the brakes of our brain so that they work and slow us down. And can you develop or get out of ADHD? Well, if those symptoms slowly decrease by the time you're 26 and 28 and you're functional, and we go through all the screening tests and it looks like you're actually doing pretty good, then at that point, prescribing a medication, if you don't need it, it's not necessarily needed, right? You can still say the diagnosis of ADHD, but at that point, your prefrontal cortex should have matured enough to the point that you might not need it. Now, there are people with ADHD who, even with the prefrontal cortex maturing, will still have significant symptoms, right? So then, yeah, of course, diagnose ADHD, treat, whatever have you. Knowing that neurobiology is really important. And total side note, and sorry, a little bit of a political comment, but this is why like a lot of psychiatrists are against the idea of holding guns before the age of 18 and 21, because the parts of the brain that control impulses are not in control yet. And we know that through all of our research and literature and data. This is why suicide is the second leading cause of death in adolescence, right behind, I think, accidents or violent crime. So this is why impulse control is super important.
Wow.
Yeah. So autism, not necessarily. I don't believe you can grow out of autism.
That was a fantastic answer, and I don't think it's political when it's evidence. I mean, it's evidence-based information. And I think it's very important that you say that, and I will have a live where we touch more on suicide, but
absolutely,
like impulsivity and neurobiology. I think when you break it down to people, because some people do want to learn about psychiatry at that level, and they can kind of see, oh, this is why they do this, or this is why the stays are like that, or this is why my doctor did this, that, and the third. I like to hear it, but I know there's other people out there who definitely want to hear that as well. And I saw one good question out here. I wanted to get it, and I feel like we've already answered it, but I just like to take your take on it.
Yeah.
Final question right here. Can you have both ADHD and autism? So
absolutely, yes, you can. I think the overall idea from everyone who's learned about this talk is that autism with comorbid psychiatric conditions occurs. It's the norm. It's not the exception. You don't just have autism. And ADHD also has a lot of comorbid conditions too. OCD, Tourette's. So you can have both. How do you differentiate both? Well, if you think about like hyperactivity and you think about inattention, that's one thing. But when you're looking at ASD or autism spectrum disorder, are they fixated on something that they need that repetitiveness and sameness from? And when someone's fixated on that and they're really hyper fixated on that, is that ADHD? That's how you differentiate a lot of these things as best as you can. A child with ASD who started on a stimulant but doesn't have ADHD will have a lot of side effects to that medication, and that might not be really helpful for them. So that's also something to really consider when you think about these things. So you can differentiate the both, but it takes a lot of clinical work. It's not just like boom, that's it,
That's fantastic. I really appreciate you coming on the show to give us this knowledge, and this is important for people to know. And I believe that like when we talk to people, we shouldn't they tell adults, as your child grows, you don't have to talk to them as babies. You can talk to them as young adults, and they learn over time. Kind of the same way with mental health and the people on the internet. Like they like to know these things at this level So I'm so excited that you're able to come on and give us this knowledge. And even though I put your your TikTok handle on here, I need everybody to go follow Dr. Sue, whether you're watching it live, one of the 300 people watching it live, or whether you watch it on the back end, like later tomorrow morning or something like that. I need all of you all to go follow Dr. Sue on TikTok and also comment on his videos and say that you saw him on Facebook Live. So that way
I need to hire you as my PR person, man.
Yeah, I can have a side job as a publicist.
You're so good at this, man. All of you should definitely follow him. I love him. He's a really good guy, and he's taught me so much too.
And likewise. And you have any final thoughts before we let you go?
Just appreciative of everyone who's listening, and I also am very appreciative of all the parents on here and all the people who are really curious about their own mental health. You guys are doing really good, big steps in learning. One of the big things I say is that anything you see on here on social media or anything like that, just please look into it. Go to accredited sources like the American Academy of Child and Adolescent Psychiatry, the American Academy of Pediatrics, the American Psychiatric Association. Look up these topics and have that discussion with your doctor or your therapist or your counselor or anything like that. Don't do this alone. Don't stick to a diagnosis and completely believe it without doing the research first and talking to somebody about it, because it's really important that you get the right treatment. And we want to have that conversation with you. We would absolutely love to have that conversation with you. So that's my own 2 cents.
Yeah, no, thank you so much for saying that, because I know new people watch, from Facebook or one of the other platforms. And I always like to tell them that, like, the goal of my content is, to make it lighthearted and funny, but I really want people to get the information and feel empowered and say, okay, I think something might be going on. Now I'm going to go reach out to clinician, therapist, counselor, doctor, nurse practitioner, or whoever they have in their area. So, I like the fact that you ended with that, to let people know that we're not diagnosing them. And the majority of people know, but I put it in there for the new people to let them know that, okay, we're providing you with the tools. So, you can get ready and go to war and take care of yourself. And then you can reach out to the appropriate professionals in your area to get that help. So that's awesome.
I appreciate it, man. Thank you so much for having me tonight. It was wonderful.
Anytime. And for those of you all who are watching, thank you so much for your attention. I appreciate it. And I will see you all again tomorrow. Peace. Take care.
Good one.
All right.